Welcome everyone to the Mended Hearts Chapter 94 National Capital Region February support group. We're all glad that you're here. Today we have an especially exciting speaker. So I'm just going to talk. I'll do a very brief introduction and we'll really swing it right to our featured speaker, Dr. Doug Morrison. Probably the best way to introduce Dr. Morrison is with this. This is Dr. Morrison's memoir, came out recently, Different Drummer, a cardiologist's memoir of imperfect heroes and care for the heart. Before anybody asks, I don't get a commission for anybody that buys this book. I wish I did, because it is going to sell, I think, very, very well. I've read quite a few physician memoirs over the years, and they of varying quality and everything. This one is absolutely riveting. It's absolutely amazing. Without going into any detail, in his own words, Dr. Morrison finished his medical training in 1984, started his career as a clinical cardiologist, invasive cardiologist, and a number of other things. Very shortly after that, he ran into some serious trouble. He ran into trouble physically, and he went into trouble emotionally, and reached out, got a lot of care, got his career on all burners, and has had an incredible career. In over the course of 31 years, he taught, he treated thousands, tens of thousands of patients at 4 VA hospitals, Veterans Administration's hospitals around the country. And in his spare time, he picked up a PhD in epidemiology along the way. And he's one of those rare combinations of physicians that has excellent bedside skills, clinical skills, and is one of the leading researchers in the field as well. Dr. Morrison has spearheaded some clinical trials he's going to talk about in the area of heart disease, heart attacks, and other associated conditions over the years. He's also had serious leadership positions in a number of professional societies, such as the Sainted Society for Cardiovascular Angiography and Interventions, where we met in the last century. Dr. Morrison has quite a talk, and he's going to talk for about 20 to 30 minutes. The phone lines will open up after those 30 minutes. Think about your questions and text them in, and you can ask questions. So without any other delay here, Dr. Morrison, the floor is yours, sir. Thank you.
Well, thank you. It's a pleasure and honor to be here with the premier organization of cardiac patients supporting one another and learning from one another. The topic that I've chosen is to share with you some of the changes in care for patients with a heart attack over the past 50 years. Let me try to whet your interest with 2 quick facts. If you were admitted to the hospital with an acute myocardial infarction or heart attack in 1970, on average, the overall hospital mortality that you would be facing would have been about 30%. Fast forward to 2022, barring confounding issues with COVID, the hospital mortality is closer to 3%. In 1970, your hospital stay would have been about 3 weeks. And in 2020s, the time to treatment for the subset of heart attack patients called ST elevation myocardial infarction, or STEMI, is measured in minutes, door to balloon time, and overall stay in the hospital is more like 1 to 3 days. How did that happen? Well, I would like to share with you in a limited time 3 ideas. First, in the last 50 years, we've learned about a second pathophysiologic pattern of heart artery disease. In 1970, we would have only talked about atherosclerosis, a gradually progressive disease of aging and risk factors that took place over years to decades. That really couldn't explain the acute coronary syndromes. And what we've learned about in the last 50 years is that there is a second disease process, call it atherothrombosis. Basically, a formation of a clot or thrombus is the precipitant and cause of most acute coronary syndromes. Number two, in 1970, we knew that a heart attack or acute coronary syndrome was an ischemic syndrome, inadequate oxygen supply to meet demand. And we knew that the oxygen supply to the heart came via oxygenated blood in the heart arteries. We didn't have a means of increasing the flow or reestablishing acutely interrupted coronary artery flow in 1970. So we were left to try to reduce heart demand. And that's why we put you in a dark room at bed rest and kept you in the hospital for 3 weeks. Number three, how do we know that that's made any difference, much less how much difference? Well, we've learned it from you, from study of patients. We could not learn most of the things that I'm going to tell you about from animal models or molecular biology or genetics. We had to learn it from the closed chest, spontaneously breathing, conscious human model of disease, namely patients. And so without you and voluntary participation of patients like you, I wouldn't know any of these three things. Now, I would like to suggest that all of this is the result of the work of heroes. And on one level, I think most of you, especially if you've had children, know that the way most of us learn things is to watch someone else and imitate their behavior. And from that standpoint, we could say that heroic behavior is behavior worthy of imitation. But on the level of visceral heroism or heroes, the level where our hearts beat faster, our palms become sweaty, to be truly heroic, this imitation-worthy behavior must be against some element of uncertainty, risk, or danger, so that the hero must call upon courage. And it's very customary for doctors to refer to various doctors and scientists in their field as heroes. But again, the real message of my talk to you all, the largest support group of cardiac patients, is the people that really brought the courage to the Cath Lab and the operating room and ultimately provide the data from which we learn, are you, the patients. So let's start with a couple of heroes. Mason Sones was a radiologist in Cleveland, Ohio. I must say he reminds me in many ways of my late father, who was a physician in Pennsylvania. And in 1958, Sones was taking pictures of the aorta of human beings with a catheter. And at that time, the idea of injecting dye directly into a heart artery was greeted with horror. And this wasn't a fantasy, it was based on animal experiments where most attempts to inject dye into the coronary arteries of animals led to immediate cardiac arrest from which they couldn't be resuscitated. In any case, on one fateful day when Sones was injecting dye with a power injector through a catheter, that catheter jumped forward into the right coronary artery of this patient and injected 40 cc's directly. In those days, the operator was in a well underneath the patient and the imaging device. Sones pulled the catheter back, yelled, coughed, and came charging out of that area with a scalpel in his hand. Because in 1958, the only major method of cardiac resuscitation was to cut open the patient's chest, reach in and massage the heart with his hand. Fortunately, a couple of coughs and the patient regained a regular sinus rhythm. And in that moment, Sones realized he had gotten away with something amazing. Over the course of his life until his death in 1985, Sones convinced some 50,000 patient heroes to allow him to inject much smaller amounts of dye and much better dye into their heart arteries and generate pictures. And this is the kind of picture that one generates with injection of X-ray dye. Now, I want you to notice here, the arteries travel on the surface of the heart in the two planes made by the perpendicular walls that separate the oval or football-shaped heart into four chambers. And traveling in those planes, on the surface, they look to early anatomists like crowns, and Latin was the language of anatomy in European tradition. And so the heart arteries became the coronary or crown arteries. The second point I'd like you to notice is that as the dye goes down these arteries from the catheter in the upper left corner, despite all the turns and branches, they are for the most part smooth and tapering gradually. But there is one point marked with the arrow where it is not smooth or gradually tapering. That tight constriction is a stenosis, the hallmark lesion of atherosclerotic coronary artery disease. And you can see from this that coronary angiography became a diagnostic technique among patients. Now, at the same time, there were many people trying to develop methods to treat coronary artery disease. And these pictures led surgeons at Soane's Cleveland Clinic to consider mechanical ways to bypass the heart arteries. René Favellaro was an immigrant from Argentina. As such, he initially was assigned to the dog lab, but he demonstrated brilliance and was quickly invited to work on the dog experiments, and then from there made his way up to the human operating room. And in 1967, he was one of the first, if not the first, to use the new heart-lung bypass machine to safely take a segment of vein from the patient's leg and construct a bypass from the aorta to the downstream artery beyond Soane's obstructions. By 1973, Favellaro had convinced more than 4,400 patient heroes to allow him to attempt that operation. 37 of those patients were actually suffering a heart attack at the time they were put to sleep and taken to the OR, or taken to the OR and put to sleep. Now, this dapper gentleman was a German-born radiologist working in Switzerland, and he was aware of work done by a number of radiologists around the world trying to use Soane's catheter technique to identify blockages and force wires and various things through those blockages. He came up with a novel idea of developing a balloon catheter small enough that the deflated balloon could be forced across a blockage, positioned on it, and inflated. I think that you can see that there's a resemblance to Errol Flynn of Dr. Grunsik, but what you can't see in a picture is that he was charismatic and could convince people to allow him to attempt his procedure, in part because he won all of us over to the notion that we were part of his team taking on coronary disease. He was brought from Europe to Emory University in Atlanta, where there were large teaching courses. His career was meteoric. He died in 1985, like Soane's. But in that brief period, he taught hundreds of us, and I count myself among the number because I went to 2 of his Emory University live teaching courses before his tragic death. And what he showed us was that it was, once again, possible to put a balloon catheter into a human heart artery and inflate it and improve flow through that artery. There was danger, and in his first case and virtually all cases before his demise and through most of the 20th century, we had surgeons on standby so that during the 5 to 10% of cases where the balloon would cause an interruption of flow that we couldn't treat, Those patients were rushed off to the operating room for an emergency surgery. Another part of his perspective then, trying to protect his new technique, was to emphasize careful selection of stable, low-risk patients. And in the 2 courses I took, that was a major part of the course. Now, it's to be expected that some physicians were going to try to extend the envelope. And this gentleman, Mayo Clinic trained Jeffrey Hartzler, known affectionately as Cowboy Jeff, set up shop in Kansas City. And he basically took Grunzig's proscriptions and used them as a virtual list of what patients he wanted to attempt. I took one of his live teaching courses, and in 2 days, he did 10 patient angioplasties. Every patient was from one of Grunzig's lists of patients that we should not touch, including a patient brought up from the emergency room with an ongoing acute myocardial infarction. Hartzler's work set the stage for taking this to the next level of unstable patients, including acute MIs. So by the end of the last century, we had reached the point. Bypass started in 67, Plasty started in 77, where both were initially applied to stable low-risk patients, and both were compared against medical therapy in prospective randomized clinical trials. Through most of the 20th century, Plasty was nearly always performed with surgeons on standby. And this leads me to the topic of relative clinical efficacy and safety. Efficacy and safety are the mantra of the Food and Drug Administration for new drugs and cardiac devices. And epidemiologic studies where we compare rates in different patient groups are the way that these things are tested. The background question across medicine is compared to what? So if you have a readily available, safe alternative, there's no risk, there's no reason to be investigating dangerous things that are not likely to be any better. And all of these trials are statistical. They come up with an answer somewhere between 0, not going to happen, and 1 happens every time. And about the only thing that's certain in medical care is that we will all eventually die. So most studies and most trials find an intermediate response. And what I want you to pause and consider, particularly those of you who have participated in a trial, is that part of the ethics in a society that values patient autonomy of the conduct of randomized trials is patients must be informed that in a trial, you don't get to pick your therapy. Most trials are compare 2 things, a standard form of therapy and a new therapy or drug. Patients are randomized 1-to-1. And in order to ethically ask a person to allow us to randomly assign, we have to have sufficient belief in the new therapy to expose half the people to it, and sufficient doubt to withhold it from half the people. That equilibrium is called clinical equipoise. And again, if you think about it, once the therapy becomes accepted, most people, there is no further equipoise, and people are not going to allow themselves or their patients to be randomly allocated. Now, I should also mention that over the most of the 20th century, Plasty became technically much better. And the main single mechanical device which changed things was the development of slotted metal tubes, which could be mounted on a deflated balloon to cross the lesion. And then when the balloon was inflated, these stents would be deployed into the wall. They would remain there like a scaffolding in a tunnel. And with the use of stents, first of all, the angiographic and clinical success of the procedure increased from the roughly 65% in the immediate period of Andreas Grunzig to closer to 95% today, depending upon patient selection. Number two, I mentioned that we had surgeons on standby because of the 5 to 10% incidence of acute occlusive syndromes. Those syndromes were largely eliminated by the development of stents. So angioplasty is now performed even in hospitals like the ones I've worked in Yakima, where there wasn't even cardiac surgery available. A third major problem with angioplasty initially was that even when it was successful and patients went home with relief of their symptoms, in 6 to 12 months, as many as 30% would be back with recurrent symptoms, and an angiogram would show that tissue had regrown in. This was called restenosis. Finally, the mere thought of using metal in an artery was quite controversial, because in animal models, you can reproducibly thrombose or clot off an artery by just putting a piece of metal in it. And that principle is used to this day by interventional radiologists who put coils in brain artery aneurysms so that they will clot off and not rupture. Now, you might consider that between 1967, when Favillaro began the bypass revolution, and 1977, when Andreas Grunzig did his first case, there was a 10-year period where we are still admitting heart attack patients and telling them we have no accepted means of increasing blood flow, so we're putting them at rest. But in fact, there was an option, and that option was bypass surgery. The problem was that most surgeons and most patients assumed that it was much too dangerous. There was one brave group of cardiologists, cardiac surgeons, and patients, Spokane, Washington, where between 1972 and 1976, over 800 patients with presumed heart attack went directly from the emergency room to the Cath Lab, where they underwent angiography that showed they had blocked arteries. And then they went directly to the operating room, where they underwent open heart coronary bypass graft surgery. That experience showed that both of those things could be done relatively safely and with relative efficacy in relieving ischemia. That experience was a tipping point. And I would submit that the main reason I'm capable of making the first point of this talk, namely that thrombus causes most acute coronary syndromes, is because of the Spokane experience. Now, if you look into the history of this, heart attack was called coronary thrombosis for 100 years because pathologists had found clots in the arteries of patients who had died from heart attack. But in the 1950s, obeying another mantra of epidemiology, association does not prove causation, there were a number of pathologists that advanced the notion that these clots were likely post-mortem artifact, that the causal chain went heart attack, death, cessation of blood flow, clot. So the clots were not causative, they were post-mortem artifacts. But the Spokane patients were living patients with ongoing heart attacks. They went to the Cath Lab, where they were shown to have occluded arteries. They then went to the operating room, where the surgeons opened those arteries in preparation for a graft. They found what looked like clots. They pulled them out with tweezers, put them in a jar, and sent them down to the histologist, who said, "Yep, that's a fresh clot." And he in turn gave it to pharmacologists and biochemists and said, perhaps you could develop drugs to dissolve this. And that was the beginning of another field of inquiry, thrombopharmacology. Now, even though they could not pull off a trial and the technique never became widely accepted, in the early 80s, these investigators looked back and did something else that's changed heart attack care. First, they looked at all of the patients in their group, and it was about a third, who had an EKG change called ST elevation on their admitting electrocardiograms. And when they reviewed the angiograms from those patients, they found that over 80% of them had a complete blockage. The implication of that is that if you don't get that artery open quickly, meaning minutes to hours, everything, all of the muscle downstream from that blockage is going to die. And these are the patients where throughout the world, when we see this pattern, we try to get them into the Cath Lab and get those arteries open as quickly as possible. A little later, they looked at all of their remaining patients, those who did not have ST elevation, and 2/3 of those patients did have some flow down the artery, albeit they had high-grade blockages and usually had reduced flow. That group of patients, we learned that we could try medications first, blood thinners and antispasmodics and so forth. And if the patients become pain-free and have resolution of their EKG changes, we may not have to get them into the Cath Lab that night, but we still do a cath and usually a stent procedure before they go home in a day or two. When I look back on that and ask myself why during that 10-year period bypass didn't catch on, other than the fact that it's a huge logistic, it's a huge morbidity for patients, it's a group that were known to be among the highest risk patients for bypass. I think the real answer comes down to the absence of clinical equipoise, the sufficient belief versus sufficient doubt. And to my knowledge, no randomized trial has ever been done that was limited to heart attack patients, and then they were randomized to either receive bypass or not. To my knowledge, there's only one trial comparing bypass surgery to angioplasty that has included patients with ongoing heart attack. It was a very small subset, and Normie Linsky has referred to that trial. It's one that I'm intimately involved with because it was a major part of 15 years of my life, a 16 hospital, 5-year Veterans Affairs cooperative study that we modestly called the Awesome Trial. But unfortunately, I think in 30 minutes, I don't have time to go into that. So I think if you really want to know about it, you'll have one of several choices. You could read my book or invite me back. Now, before I finish, I want to go to a final hero. David Sackett was a wonderful Canadian doctor. He certainly was not the first clinical trialist. And I don't know who was. I think in Western tradition, meaning Judeo-Christian tradition, I would nominate Daniel from the book of Daniel. And you can look up the trial that he proposed to the Babylonian king. It was neither randomized nor blinded, but it was a trial of sorts. What David Sackett did was teach a whole generation of internal medicine doctors how to apply epidemiologic thinking. He wrote a textbook, which for me is the best ever, called Clinical Epidemiology, a Basic Science for Medicine. His work then metastasized to all 18 medical colleges in the great nation of Canada, and he definitely was a pioneer of the use of comparative studies of patient groups to change how we take care of patients. The efficacy and safety of both bypass and Plasty were initially compared with medical therapy in randomized clinical trials, and then they were eventually compared with one another, just as patients initially were limited to stable low risk and then more unstable and high risk patients. This whole process has been dubbed the quest for evidence-based care. And I think most physicians across medicine would agree that the randomized clinical trial has transformed medicine from a system of habits based on local lore and custom into a real scientific discipline. We went from small trials to multi-center trials. In the 90s, mega trials were begun, and I've listed two that ushered in the reperfusion era. GC stands for Gruppo Italiano per lo Studio della Streptokinesi Investigation. The entire nation of Italy organized its cardiologists and coronary care units, and in 1 year randomized 12,000 heart attack patients between standard care alone versus standard care plus intravenous clotbuster streptokinase. They demonstrated a highly significant improvement in short-term and long-term mortality after a heart attack with that intervention. ISIS stood for, before Syria, the International Study of Infarct Survival, and there were 4 ISIS trials run by epidemiologists and statisticians from Oxford University. ISIS 2, I would submit, is one of the most important trials in all of medicine. There were 18,000 patients with suspected acute myocardial infarction, and they did what they called factorial randomization, so they could test 2 treatments at once. One group of 4,000 plus patients received oral aspirin and intravenous clotbuster streptokinase, the same drug as in GC. Another group received 2 placebos. A third group had aspirin and an intravenous placebo, and a fourth group oral placebo and intravenous streptokinase. And at the end of their trial, they demonstrated the statistically significant differences in survival between 3 cut points. The worst survival were the patients who got 2 placebos. By far the best survival was among patients who got oral aspirin and intravenous streptokinase. And the 2 groups that got one or the other had pretty nearly comparable survival curves, suggesting that both of these treatments work, and they work in an additive fashion. And between these trials, we have been giving aspirin and some effort to open arteries pretty much ever since. In the late 90s, smaller trials, they have to be smaller because it's easier to get people to accept clinical equipoise of 2 drugs than it is procedures. But trials in the 90s compared a variety of angioplasty methods with and without stents against various clotbusters. And since that time, anywhere in the world where a heart attack patient can be transported to a Plasty capable center and moved into the Cath Lab for a door-to-balloon time less than 90 minutes. Plasty is the indoor champion. So I've tried to introduce you to 6 of my favorite medical heroes: Mason Sones for coronary angiography, Renee Favillaro for coronary artery bypass graft surgery, Andreas Grunsig for balloon angioplasty, Jeff Hartzler for extending the application of balloon angioplasty to patients with acute myocardial infarction, the Spokane cardiac surgeons for extending the application of emergency bypass to acute myocardial infarction, and David Sackett and many people like him to the application of clinical epidemiology methods to see which works best. But in all these, the meta theme of this talk is that the people who really brought courage to the table, and I mean table, pun intended, Cath Lab table, operating room table, and who provided the data were patients who were voluntarily participating. How did these heroes change the behavior of cardiology providers? Well, supposing you're having a heart attack and you're in the emergency room of your local hospital. And I came to you in that emergency room as the cardiologist who had been called. And I said, sir or ma'am, you're having a heart attack, and we want to take you to the Cath Lab and identify a blocked artery and open it immediately. In 1970 and probably in 1980 in most hospitals, you would have likely said to me, are you insane? I'll sue you if you kill me in the cath lab. But in 2020s, you're more likely to say, Doc, how fast can you do it? Because don't forget, time is muscle, and door to balloon time is a quality indicator across the world. So these are the three topics. In the last 50 years, we've learned that there are two flavors of coronary artery disease: the slowly progressive atherosclerotic flavor and acute thrombosis, which causes most acute coronary syndromes. We've learned to increase the flow or reestablish flow to arteries that have been blocked. And in the emergent setting of acute heart attack, everywhere in the world, from Beijing to Moscow to New York to Washington to Yakima, Washington, if patients can be transported to a hospital with a cath lab and people there who are trained in doing it, the best choice is emergency angioplasty with stents. And how do we know all that? We know it because patients have participated in randomized clinical trials and prospective registries. So I would say that all of this, the real heroes, are the voluntary participation of patients. I would say that September 6, 1977, Andreas Grunsig inflated the balloon heard round the world and initiated the coronary angioplasty revolution. But the beating heart of that revolution has been the courage, determination, and perseverance of patients as well as caregivers. And I would also say that the lifeblood of the quest for evidence-based medical care will always be the voluntary participation of patients. And for those of you who would like to hear more about this, well, there's a new book, Bob, and it's not called Baby Steps. It's called Different Drummer. Thank you very much for inviting me and allowing me to share these thoughts with you. And now, bring it on.
Thank you, Dr. Morrison. Anyone that wants to ask him a question, please unmute yourself and ask.
Hi, doctor. How are you? Thank you so much.
Thank you.
What a wonderful presentation, and it's so wonderful to know about your heroes and obviously my heroes too, because I'm a heart recipient, since 2015. And so thank you again. I just had a question, I guess, at more of a comment too. So back in 2008, I did have and I learned some of this from your presentation just now, an acute MI. And I'm not a doctor. I had that, and I guess it was an ST MI based on the fact that I was experiencing some symptoms, but I didn't really know what they were. They were not typical, chest heaviness and stuff. They were back pain, and I thought it was indigestion for several hours, like maybe 4 hours. I tried to resolve it. So my question is, I was taken eventually to the emergency room where I saw the emergency sign and I collapsed. And then people were telling me I was having a heart attack and all this stuff. So they took me into the ER, and they transferred me actually to another hospital where they could do a angioplasty for me. So my question is, do you think the most of my muscle damage happened because I ended up waiting that long after suffering my heart attack? And of course, you wouldn't know. This is just speculation on your part, but is that what's your opinion on that? And if they had done bypass at the time, would I possibly have not needed a heart transplant?
Well, these are all speculations now, years after the fact, without the key information. I think for me, as a cardiologist, the first point of your story is that all of us as humans have to acknowledge uncertainty and when we're not sure, call for help. Now, no one wants to, take an ambulance ride and go to the hospital and get hit with an emergency room bill, but you've described a number of the key conundrums in one case presentation, and at the risk of sounding glib, a lot of it is even worse for the ladies, because ladies more often have atypical signs. For years, even one of our heroes at the turn of the previous century, William Osler, used to say that angina is a disease almost exclusively of men. And the problem was that men far more often develop substernal squeezing pain and make the squeezing heart sign, known affectionately as Levine sign. And more often women have nausea and sweating and lightheadedness, and there's a whole range of symptoms. What basic life support classes and the American Heart Association, and now I'm sure your organization, when I say I'm sure, I've gone on your website and looked up heart attack. All of them try to encourage is when you have any of these symptoms that could possibly be a heart attack, you activate 911. And the point of 911 is that then emergency medical technicians come to you, and nowadays they not only have the defibrillator and the IVs and the oxygen and all those things, but they get an EKG right at the scene. And if you did have ST elevation, as seen by the EMTs at your home, then number one, they would likely transport you to the closest center that's capable of doing emergency angioplasty. In my years in the VA, for example, even in big cities, I was with the Seattle VA, the Denver VA, the Tucson VA, the Tampa VA, and the Pittsburgh VA. Those are big cities. And in all of them, if a veteran calls 911, usually they will not be taken to the VA, even though they say, I'm a veteran, I want to go to the VA. No, they're not equipped for emergency angioplasty in most cases. As Cath Lab director, I tried to make Tucson and Denver equipped and ready, but it was very difficult to have a call team. And sometimes I would have to just go across the street or across town and cath and angioplasty my veteran in the university hospital. So the point is, the first and biggest delay is almost always the patient. And this is not a judgment, but it's a fact. And it has been a fact, and it was known 50 years ago, that most of the deaths from heart attack occur early. And most of them are arrhythmic deaths, where if ventricular fibrillation is recognized, there's a defibrillator, and people trained and authorized to use it, your life can be saved. So when you have any of these kind of things where there is a question in your mind, you should not sit at home. You should not take and chew aspirin or antacids. You should certainly not drive yourself to the emergency room. And if you live in my neighborhood, you should not come and flop yourself down on my door. You should call 911. And then you can call me and I'll meet you in the emergency room. But nowadays they would get an EKG and get you in much more quickly. Now, as for the next part of your question, any delay is bad. If you arrest, one of the reasons that the best place in the world to have a cardiac arrest is Seattle, is that two things determine the likelihood of survival and arrest. One is how quickly people who know how to do it begin what I lovingly call Arizona CPR, which is hands-only compressions to the tune of the Bee Gees hit Staying Alive. The second thing that determines whether you're likely to survive is how quickly they can get a defibrillator to you with people who know how to use it. And in Seattle, the city is blanketed. Fire rescue can get a defibrillator almost anywhere in 8 minutes. And something like a quarter or a third of Seattle's population has been trained in doing CPR. So no delay, or minimal delay on your part. Find out you have a STEMI, then get you to a Plasty capable hospital, then get you in from the emergency room door to the first balloon inflation in less than 90 minutes. Now, how would we know the answer to the next part of your question, whether the delay and all that is why you wound up years later with a transplant? Well, if you came out of your first heart attack hospital stay and your EKG showed the Q waves that we used to think suggested completed full thickness heart attack, or better yet, if an echo or a nuclear study showed that the walls supplied by the artery and the territory you had your heart attack weren't moving, then yes, I think that contributed to development of heart failure and ischemic cardiomyopathy. If for whatever combination of circumstances they got you in fast enough and got you stented such that by the time you went home, those walls were moving, then I think it's probably subsequent events that led to your cardiomyopathy and ultimately your heart transplant. So I think you've asked me, if I understood it, about 3 questions, and I've tried to give you 3 speculative answers.
Awesome, awesome, doctor. I mean, obviously some people did many things right, so I'm here today to ask these questions. But you know, I also learned my lesson, and I tell people all the time, don't wait. You know, I did have a lot of Rolaids and Tums and stuff like that to resolve it, but appreciate your response and your detailed response. You know, so thank you so much, Doc. It's a pleasure to listen to you.
Well, thank you, and thank your colleagues and comrades. Your organization is totally awesome. As I told Normie when I went on the website, I realized the founder of Mended Hearts, Dwight Harkin, was the father of Alden Harkin, who I worked with at Colorado for some 10 years. And I just think the purpose, the goal of your organization is incredible. And if by doing things like this, we can encourage people who, you know, especially ladies, especially elderly, especially people with diabetes, those are all 3 groups where you are more likely to have, or as likely to have, nausea and vomiting, or acute sweating, or acute shortness of breath, palpitations, as you are to have the crushing substernal chest pain. And any of those should be reasons, especially if you have a history of risk factors and or a history of prior cardiac events, to call 911. And it is better to be embarrassed, if you will, because you came in and they say, well, your tests are negative. And we all know how doctors can sometimes say that your tests were negative, you know. So you feel well, excuse me, sorry to bother you. I joke because this is one of those situations where if you don't laugh, you cry. But it's better to have that and have a heart attack treated promptly. I'll just give you another example. Heart attacks on the bottom wall of the heart, that frequently touches the diaphragm, which is the big muscle that separates our chest from our abdomen. So a heart attack on the bottom wall of the heart is frequently associated with nausea or vomiting. It sometimes can lead to uncontrollable hiccups. Part of my sick coping skills was to take rock and roll music and rework the words and make classics of Cath. So there was a song by Pink about I'm coming up, so we better get this party started. And with the frequency of people coming in with nausea and throwing up, I used to like to sing, I'm throwing up, so we better get this Plasty started. So that's an example of atypical presentation of a heart attack, as you described.
Yeah, thank you so much, doctor, because I learned my lesson. And also, I was a young guy who never wanted to go to a doctor, let alone go to a hospital.
Oh,
And,
five.
You know what I mean? So 2008, I learned my lesson. Thank you so much.
Why would you not want to go to doctors? We're wonderful.
Nothing was broken, doc.
Anyone else have a question?
We can take care of that.
If anyone has a question, please just ask it.
Yes, Ed.
Doctor,
Yes.
it's a great presentation. Thank you.
Thank you.
Thank you very much.
Doctor, I have a question. This is
Normie.
Normie here. I have a question. You talked about a minute or two ago about how you looked at the Mended Hearts website and kind of got a feel for what we're doing, as well as worked for 10 years with our founder's son, who also is a cardiovascular surgeon. The importance of peer-to-peer support, patient-to-patient support. Most of the people on this screen right now, many of our other friends in this chapter and elsewhere, in addition to being heart patients, themselves are trained visitors, have been people that have spent, literally looking at the screen right now, thousands and thousands of bedside visits with patients, people and families in the hospital. And they miss it. We miss it terribly because of the pandemic. We are doing everything virtually. We're looking forward to get back into hospitals and again, providing that kind of support. Can you talk for a minute or two about the importance of peer support, family support as part of someone's heart attack journey and recovery?
Well, you know me, Normie, I could probably talk all day. You'll probably get the hook. I will say, first of all, in response to you, that another group of my heroes were VA volunteers. One of the friends, he unfortunately just passed in January at 92, brought my wife and I together. He retired, I think, late 60s, early 70s. His daughter was in the Navy and he volunteered for the VA. But by the time he was done, he had logged over 50,000 hours as a VA volunteer. And he was present at the moment of death of a lot of US veterans. The education he provided, the support he provided, it's incalculable. Honestly, I don't personally have experience as a patient with cardiac disease, I guess I should say, thankfully, and so I haven't had a support group, but I have taken advantage of support groups of other types, and I think it's I think what you're doing is tremendous. You help, just as the website says, with education, with support, and with advocacy. And I think you're absolutely right. The loss of in-hospital volunteers, the loss of support are just part of the many prices that we've paid to try to survive a international pandemic. And I will say in passing that my only brother didn't survive it and died of COVID. So I think the intent of staying out of the hospital when it's filled with people with highly infectious and potentially lethal disease makes sense. But I hope as we get more and more people vaccinated, we will get back to some semblance. And I think then real face-to-face meeting in the hospital and out of the hospital is of incalculable benefit. I think it's incredibly important from the perspective of patient compliance. to name another example. But I hope the kind of interaction we just had about pre-hospital, the educational component is critical. So I'm really grateful to have this opportunity and to meet you folks and see what and hear what you're doing. And I would love to be more of a part of it.
Wonderful to hear that, Doctor. And thank you so much for your comments there. I have one last quick question. Does anybody else here have any other questions? Any other questions? I've got one I'm really eager to ask. One brief question from yours truly, and then we can close out here. Your Dr. Morrison, the historical perspective you brought to the table today was incredible. These heroes that have been giants that people like you have stood on the shoulders of to get where we are right now. It's really been impressive. Is there one thing right now, looking towards the future, one development, either research or pharmacological or devices or techniques or anything? Is there one thing that gets you especially excited about what's going to come next in the coming years in your profession?
It's funny. When I went to medical school, I felt like the thing that was really held in high esteem was basic science. And part of that was that most people agreed molecular biology and genetic biology and all these things were where ultimately cancer and heart disease were going to be cured. And I will confess that I wasn't that enamored of basic science in medical school. And I like to tell people about a dream that I had during the first year of medical school. And in that dream, it was announced that basic scientists had cured cancer. And that was followed promptly by mass protests in your city, Washington, D.C., and elsewhere. This is in my dream. People were marching with signs like the Gadsden flag, don't tread on me. Doctors can't make us take the cure. I don't know if that dream was a harbinger of things to come, but I know that throughout my career, patient compliance has been an issue. And we learned as a country with prohibition, we haven't learned our lesson with drugs so well. It's hard to make people do things, even when you're absolutely certain that it's in their best interest. So what I'm excited about is just what I spoke to you today about patient participation in clinical trials and changes in diagnosis, treatment, and prognostication based on patient experience. And I think that's been as big a revolution as any, and it's being applied across the board. There is no vaccine, there is no cancer chemotherapy, there is nothing from percutaneous valvular treatments to support devices for more and more unstable patients getting bypass or angioplasty, where randomized clinical trials aren't where the rubber meets the road and we find out what works and what doesn't. So I think, in line with your other question about support groups, an awful lot of this then winds up being, when we know something, how do we convince ourselves and each other to do it? And I think that's another area where peer-to-peer support is huge. I don't think we're going to get the final, 25 or 30% of Americans vaccinated against COVID by yelling at them that they're uninformed or what have you. I think we need to, let them convince themselves, and peer-to-peer support and peer-to-peer education and data that's based on randomized trials, when you realize that literally hundreds of thousands of patients have been randomized between the mRNA vaccines and placebos, and we know exactly how effective and safe they are in various ways. Well, that's so. I'm excited about clinical research, its application, peer-to-peer support, changing people's lifestyle. You know, if you ask me another one of the biggest things in my 50 years as a cardiologist, and I frequently tell my kids this, when I started, we spent all kinds of time asking people detailed family history because we were so sure that genetics was such a big part of atherosclerotic disease. By the end of my career, I rarely asked patients about their family and history of coronary disease unless they volunteered it, because the impact of stopping smoking, getting your blood pressure treated, cholesterol lowering, triglyceride lowering, regular exercise, fruit and vegetable diet, it dwarfs the genetics for most patients. It is a largely preventable disease. But it involves lifestyle, and how do you get people to change their lifestyle? So those are the things I'm excited about. How about you? What are you guys excited about?
Mr. Himmelstein.
Hey, Doc, Dr. Morrison, I'm excited about your book, but I'd like you to tell us a bit more. We saw the name of it and everything, but if you wouldn't mind, just share some more, a little bit of insight so we can go get that book.
Okay. It is a personal memoir. So there is a lot about my first two medical heroes. My father and stepmother, both physicians, and my mother was a teacher. There is a chapter about various education and training. Normie made me a lot younger than I am. I finished medical school in 73, and then finished residency and fellowships by 80. 84 was when I had the disc. And the importance of the disc is that, and it's dealt with in the book, I had spent by that time 19 years post high school, and I really was, relocated with two infant children to Denver to become a Cath Lab director and get on board Grunzig's train, the angioplasty revolution. I got this cervical disc where my right arm was 3 inches smaller than my left, and I had no triceps function, and the neurosurgeon said, "You're done. You will never cath an angioplasty again. What are your major coping strategies?" I said, "I jog, lift weights, and do martial arts." And they said, "Good, you'll never do any of those again. What are you most afraid of?" "I'm most afraid of being quadriplegic." "Well, that's funny. We want to do neurosurgery on your neck." And my wife at that point said, "You know, I didn't sign up for all this." So to say I was depressed is to understate the case. I wound up refusing the surgery, quite a model for people I'm talking to about surgery. I did physical therapy with traction instead, got a complete cure, but I also started, and this is the real answer to Normie's questions about support groups. I saw a psychiatrist once a week for 20 years during the periods I was doing high-risk intervention in Colorado and Tucson. So I think the book has something to offer for caregiver burnout, depression, substance abuse, and suicide. During the writing of the book, for example, one of my cardiology partners committed suicide, and there have been way too many doctors over the course of my career. So that's another piece, getting help and going to a variety of support groups. And then there are chapters about putting together a book, making the case, getting the VA to fund a prospective randomized trial. The book is a lot about the United States VA because the VA is the largest healthcare system in the United States, and it's the most maligned. There is a general notion fueled by one party that anything the government does is inefficient and no good. And that notion fuels the notion that VA care is second rate. The first revelation for many of you might be that there's no major medical school in the United States, or very few, that don't do 40% of their teaching at their affiliated VA. So when you go to the Seattle VA, you go to the University of Washington. And when you go to the Denver VA, you're going to the University of Colorado. When you go to the Tucson VA, you're going to the University of Arizona. When you go to West Roxbury, you're going to Harvard Medical School. Teaching and veteran care are their first two missions. But the VA also, because it pays so much less well than private practice, has known since World War II they weren't going to get good quality physicians unless they had an inducement. And they built what is one of the best clinical research infrastructures in the world. The only thing better and bigger in the United States is the National Institute of Health, maybe the British Medical Research Council. So they have a program to do VA cooperative studies. What we were able to get funded was a randomized clinical trial between bypass surgery, angioplasty with stents for high-risk acute coronary syndrome patients. And we got them to also fund a prospective registry because we were aware of clinical equipoise, and a lot of the patients were not going to be able to be randomized. So those are big chunks of the book, and then much of what I shared with you today. So that's a long-winded introduction, and thank you for asking.
Appreciate it so much. We're gonna go get the book, hopefully. Thank you so much. The link is in the chat, by the way.
Yeah, check the chat box, everybody. Thank you for Sam for sending that one out to everyone. Dr. Morrison, that was amazing. That was incredible. We have to say one thing, that we appreciate the fact that you spent so much time with us here today. We actually have more questions. I'm joking when I say this, we have a little bit of bad news here. You said twice during this conversation, we have it on tape twice, if you get invited back, well, it's on tape. And that invitation, if you're willing to accept it, is going to come a lot sooner than you might expect. So
take it off the video.
Absolutely. That we have it on video. We've waived the dues, by the way, for chapter 94. You're now an official lifetime member. We'll crank out a certificate for you on that one. And we just can't thank you enough. And unless anybody else has anything else they'd like to say, Dr. Morrison, closing remarks from you, sir? Thank you, Dr. Morrison. It's been a wonderful conversation. We'll be talking again soon with you.